as I kick off as a presenter in this conference, I would like to engage you on our view as HuQAS on the new requirements of ISO 15189, especially on the requirements for IQC and EQA. I'm so sorry for coming in between you and the tea, but just allow me a few minutes to discuss this subject, and then from there we'll be guided on how to proceed. So I'll be talking about maybe three things. One is on the background on ISO 15189. Then from there we look at what are these new requirements or these enhanced requirements on IQC and EQA as per the new standard of 15189. And then finally we can draw our conclusions or what we feel about these new versions of the standard in regards to this subject of IQC and EQA. So you may be aware that we have come a journey in terms of ISO 15189 development. Before 1994, there was no one guideline, there was no one standard to harmonize laboratory quality globally. And from that point, we had CLSI writing to ISO, the International Standardization Organization, and requesting them, how come we have ISO standards for other fields? We have standards for hospitality. We have standards for manufacturing industry, textile industry. But you don't have an ISO standard for a very critical department in healthcare. And so ISO received this request, and for sure, they saw it very important, and therefore created a framework for having this particular standard being formulated so that we can have a harmony in terms of quality assurance for medical laboratories. It took them about almost 9 years to come up with the first draft of the standard, which was initially published in 2003. And then just like they do for other standards, they have to be reviewed every 3 to 4, 5 years. The standard was reviewed in 2007, and they were able to release the second edition of our standard. They never stopped at that point, and so they reviewed again in 2012. And then 10 years after is when they did now the fourth edition that we want to talk about today, and probably for the next few years as we prepare to transition to that particular standard. So what we'll be talking about is more of what are these new requirements of ISO 15189, the version of 2022. It was published last year in December. I know most of us, whether we are coming from South Africa, Cameroon, Ghana, and all over in Africa, we are all in the transition phase towards this new standard. And therefore, we have done a bit of cross-checking, looking at these new requirements. I may not be able to highlight all the new changes right now. You may have some idea of what some of the changes are, but allow me, like I said, to just discuss on IQC and EQA. So these are standards that you're talking about, the medical laboratories requirements for quality and competence. So in terms of the key changes, or in terms of the structure, you may be aware that this new standard has got 8 broad sections or 8 broad clauses. You may call them paragraphs, you may call them articles, but there are 8 broad clauses in it. Of course, the first thing is about the scope, the normative references, the terms and definitions, and then now directly to the auditable clauses, or from clause 4, 5, 6, 7, all the way to clause 8. that talks about management system requirements. Then at the end of this document, you have 3 annexes. One is on the additional requirements for POCT. Then there's a comparison between ISO 15189 and the further standard, that is ISO 9001. I hope you are all aware that this is a hybrid document formulated from 2 standards, that is ISO 9001 and ISO 17025. So there's an annex comparing, or what we would call really a paternity test between our standard and the father, which is ISO 9001. Then Annex C talks about the current version of the standard and the former. What are these changes between the 2 versions of the standard? So, in terms of the key changes, just to highlight, because we may not have the time to go through all of them, there are 5 key changes that you'll notice from this new standard. Number 1 is the format. Previously, we had our standard partitioned into management and technical requirements. Now, what we have now, what we talked in the structure, are the general requirements, the resource requirements, the process requirements, the management system requirements, governance, and structural requirements. So we no longer have management and technical requirements. So that format is in line with the mother standard, which is ISO 17025. Then secondly, you have the incorporation of POCT requirements. You may be aware that we used to have an ISO standard for point of care testing. Now that standard, you may not be able to hear about it again once the transition to 15189-2022 is completed. Because all those requirements in ISO 22870 have now been moved to a new version of the standard. You'll also notice an increased emphasis on risk management. I know we are used to corrective actions, corrections, immediate actions, or however you call them in your facility. Now, this new standard is encouraging us to be more proactive in how we carry out our laboratory activities, and therefore the emphasis on risk, so that we look around what can go wrong in our facilities and then initiate mitigation factors or measures before it actually happens. You'll also notice alignment of specimen management with its standard there, and also the alignment of laboratory health and safety with ISO 15190. So those are the 5 key changes that you may be aware of in this particular standard. Now, of course, there are other changes across the standard. Just to highlight a few of them, that this new standard now have fewer mandatory SOPs. So in the other version, we used to hear about the laboratory must have an SOP for, let's say, referral laboratories, an SOP for personnel management, an SOP for external services and supplies. Now, this time round, they may not call them SOPs, but they are requesting laboratories to have arrangements or to have mechanisms, whatever mechanisms you may choose in your facility, not necessarily calling them SOPs. And so we say it is less prescriptive in terms of its requirements compared to the previous standard. Now, also, there is a more emphasis on impartiality. You may call it a lack of bias, lack of prejudice, independence, addressing the conflict of interest. Now, there's more of emphasis now on impartiality, or the ethics, as we call them in our facilities, or professionalism in how we operate as a lab. Also, there's a more emphasis on confidentiality, more emphasis on POCT, In fact, asking us to have an agreement document with all users of our point of care devices. I know this has been an issue in the past where we keep asking ourselves, do we want our nurses to handle these gadgets? Do we want our clinicians to handle these gadgets? Do we want the community health workers in the field to handle these malaria rapid testing kits? Now, if they have to, because sometimes we don't have a choice, in the ICU, you will have our nurses handling the blood gas analyzers. Then it calls us now to talk about an agreement with them. What are they supposed to do as a point of care operators? What maintenance are they supposed to do? Are we the ones to carry out IQC for them? Are we the ones to carry out EQA for them? Are we the ones to carry out maintenance for them? So the standard talks about having an agreement in terms of what the POCT operators must do. Now, there's also a new requirement on sample acceptance exceptions. I know we have discussed previously about rejection, specimen rejection, specimen acceptance, and previously it was outright that if a sample is insufficient, if a sample is not of good volume, then you have to reject. Now, this new standard has got a few exceptions on some samples that you can accept, even if in your own understanding, you feel they are not up to standard. But then, as you work on those particular samples, you must give some cautionary comments that these results can be consumed, yes, but with probably a few reservations. Because telling someone to get a new histology material for, let's say, the cervix or whichever material, you may not be able to reject that sample on the mere fact that the sample was not handled in sufficient formalin or any fixative material. Now, previously we used to have a mandatory requirement for a laboratory to establish a quality manual. Now that is not mandatory in this new standard. Some of us viewed it as a repetition to have a quality manual and then go ahead and indicate the various documents that you must have in the lab. So now you may have a summary of all the other documentations in any other document, however name you call it, and not necessarily a quality manual. So that's a new requirement. Then there are more elaborate requirements on complaints and that. Then number 9 and number 10, this is now where I want us to focus on. These are the new and enhanced requirements on IQC, as well as EQA. Now, first, in terms of IQC, now in terms of IQC, of course, some of these requirements were still there in the other version. And so I may dwell a bit more on what is new or what is enhanced in this new version of the standard. Number one, you must have an SOP for IQC. Most of us have documented SOPs for malaria testing, SOPs for operation and maintenance of various equipments, SOPs of maybe complaints. Now, in your list of SOPs, you must not forget the SOP for handling, the SOP for analysis, the SOPs for troubleshooting, the SOP for reviewing IQC reports. And so, among the SOPs you are going to document, you must not forget the SOP for IQC, because this SOP will help you to define the responsibilities. Who is supposed to carry out an SOP, an IQC analysis and review of those results? Do we have specific personnel for IQC? I know in some facilities you would say IQC should be run by specific people, but then patient testing is handled by anyone. And so we must ensure that whoever handles patient samples is also in a position to run, to review, and to do any corrective actions on IQC failure or such. Now, the criteria for IQC should be specified in that IQC procedure. We have facilities whereby we run IQC every morning, and our machines are probably automated to accept or to reject an IQC run. But when we ask ourselves, do we have our own established criteria of when do we accept an IQC run and when do we reject it? Do you want to use the Westgard most rule for IQC? Now, the new standard requires us now to have a criteria for IQC acceptability. When do you say your IQC has passed? Do you follow the 1-3S rule? Is it the R4S rule? Which rule exactly are you using for review of IQC? That should be defined in your SOP for IQC. Now, there should be some consideration on clinical application of a test in IQC selection. Now, we do IQC for routine tests, but there are these tests we say, these are rare tests, or these are tests that the equipment has its own self-check mechanism for IQC. Now, the standard talks about the clinical implication of this particular test. And so, if any test has a clinical implication, then we must ensure we have an established IQC for it. Allow for detection of load change. I don't know how we do it in our facilities, but then it can also form an instance when you have to carry out an IQC. There are machines that whenever you change from one lot to another, they'll just accept you to continue with running of tests. But then, even when the machine does not prompt you to carry out either a calibration and IQC, we must ensure that moving from one lot to another, we have ensured analysis of IQC for that matter, and also avoiding lot change of IQC in the course of the day. Also, the other bit is a consideration of third-party IQC materials. This is an enhanced requirement, I would say. Previously, it was a note, or I would say a recommendation, that a laboratory can run or may run third-party IQC materials. Now we are told you must run, or you must consider the use of third-party IQC materials, either as an alternative to what the manufacturers have given you, or in addition to what the manufacturer will give you for a particular analyzer, you must ensure that you run third-party controls. Now, which one is easier? Is it to do the two of them, or to use it as an alternative? I leave that to you to answer. And so we are told we must make use of third-party controls because we all have an experience with manufacturers' QCs. Sometimes they may be, they may have a bigger range, and therefore no failure is observed in IQC. But when that same machine is subjected to an EQA, you find yourself failing, even if IQC is doing very well. And so third-party IQCs is one of the enhanced requirements. And I would therefore call all our manufacturers or suppliers who are inside the house to consider introducing IQC materials that are of third party in nature. And by that party, we mean that if your machine is from this manufacturer and they have been providing IQCs from the same manufacturer, they need to provide you as well IQCs from another manufacturer, but confirmed to be working on this particular analyzer. Because again, commutability, or what we call compatibility, is a key issue for IQCs. And therefore, your manufacturer or your supplier should have confirmed that those IQCs are actually working on that particular analyzer. Otherwise, you may run an IQC materials from other manufacturers, and then you realize they're not passing, on your machine. And therefore, let's approach it together. The laboratories and the suppliers, the manufacturers, in verifying or confirming the IQCs that are working for our analyzers. And so that is something that we really recommend. Now, select an IQC with defined stability conditions. In most of the inserts of our IQCs, you'll find out that they indicate that this IQC material is stable for 7 days when kept at these temperature conditions. It is stable for this number of months when kept to these other conditions. So on the insert, because I know we are dealing with so many manufacturers, ensure that the insert clearly indicates what are these stability conditions for the IQC materials to avoid consistent failures in IQC to the point of even condemning the analyzers. Yet the manufacturer had not defined the stability conditions for our IQC materials. Now the matrix or the environment of that QC material should be similar to what we expect in a patient sample. For patient samples you use whole blood, then even in IQC you expect a similar matrix. If the patient sample is composed of whole blood and you go ahead to use distilled water or a water-like solution as an IQC, then you're not challenging your equipment as it would be challenged by a patient sample. And therefore, you are advised that the matrix of this QC material should be similar to what you have for patient samples. So then we also advised that the QCs must cover the entire measurement range of the examination method. Now you find, like for hematology, for example, you have an analyzer that can measure WBC from, let's say, 1 to almost 50. But then the labs goes ahead and buys only one level of IQC. They buy the normal control. Now, what happens when your machine is subjected to very low samples or very extremely high samples? So you're being advised that now the IQCs we put in place or that we engage for our machines should cover the entire measurement range of our analyzers. And therefore, the issue of buying just one level of IQC is highly prohibited now in this new version of the standard. That we need to take note. The frequency should be based on the impact of this particular test. Now, when you go to most of these electrolyte analyzers, they will do their own internal calibrations maybe 3 times in a day or 4 times in a day. But when you ask how many QC results do you have for this machine, they'll only show you the IQC run that was done in the morning. So how did you verify that the other calibrations were actually correct? Because one purpose of IQC is to confirm the integrity of what? The calibration curve. So if your electrolyte analyzer is carrying out calibrations 3 times, 4 times in a day, then we expect a similar number of IQC runs, just to confirm that all these calibrations are actually correct. And so the frequency of analysis should be based upon, of course, the stability of that analyzer or that test. And the machine does several calibrations because the electrolytes are also quite unstable. And therefore, even for IQC, we need to do a similar number of IQC analysis, just like the calibrations. Then this QC data should be recorded. Now, previously it was just a note or just an advice that you should record or you should plot this IQC data in a way that can help you detect either trends or shifts. Now it's a mandatory requirement. So whatever we usually call the LJ charts, this is now somehow a mandatory requirement. Because it's only through an LJ chart that you'll be able to detect the shifts and the trends. You may be able to tell that the IQC is passing just based on the reference ranges. But the reference ranges may not help you to detect any biases in your IQC. Your IQC may be passing, yes, but bias on one side of the mean. And therefore, plotting of LJ charts or any other tool that you may want to use, any statistical tool that you may want to use, is now a mandatory requirement to ensure that you're able to detect those trends and even interpret them based on either the Westgard rules or any other multi-rule criteria that you may want to use for your IQC as a criteria for acceptability. Now, the other requirement is on prohibition of release of patient results when an IQC failure happens. We are used to running IQC every day. When you go to any facility in the morning, they have run an IQC. But then, when you interrogate the reports further, you realize out of the 40 tests they are doing, maybe 5 tests had a failure in IQC. But they are continuing releasing patient results in the course of the day without doing anything about the IQC failure. So we need to advise our clinicians that at some point, we may hold your results or we may delay release of your results based on the failure in IQC. And that should be now our culture. They should understand that these things can happen. We may fail to release the results, not because the machine is not working, not because we don't have a reagent, because that is what they are used to, not because of there's no personnel on duty, but a serious reason like failure in IQC should always prompt us to not release patient results. So this is now a mandatory requirement in terms of the new standard that we have. Now, what should happen when IQC fails? In many cases, we run IQCs and patient samples together. That happens to save on the TAT, to save on time, to release patient results as soon as possible. Now, we have a problem here because if you happen to have run IQCs and the patient samples together, and then the IQC fails, you will first of all, of course, do the correction. Like we said, you have to hold the results. But it will not stop there. You will have to repeat all the samples that you had run this batch of IQCs together with. And so that means you may get into very serious cost implications with that culture of always running IQCs together with the patient samples. And therefore, we advise, if to avoid this kind of costs, make sure your machine is working properly by running the IQCs and then subject it to patient samples. Because if you happen to run them together with the patient samples and then the IQC fails, you'll have to go back and do what? And retest the affected samples, just to confirm that they were not affected by the same problem that affected IQC samples. Now, finally, on IQC, we now have another problem or another requirement or an enhanced requirement that if you had run an IQC yesterday and it passed, very good, you proceeded with patient testing the entire day. Then today in the morning, you ran them and they fail. Now the standard requires to do an examination or evaluation of the samples run since the last successful IQC run. Now you get this. I don't know whether it has sunk. You ran the IQC yesterday. It passed. Very good. And you proceeded with patient analysis. Then today, you run your IQC, it fails. You're being told, when IQC fails, it shall be corrected and results from patient samples that were examined after the last successful IQC event shall be evaluated. You get that? Now, evaluation may not always mean repeating. We need to be clear. Does not mean that you have to repeat all the samples that were run yesterday. But evaluation then means you need to have a closer look of how the results were behaving, probably in relation to the clinical history of this particular patient. But the end result may involve repeating some of the samples randomly. You get? So besides just correcting the IQC today, and you say the IQC is fine, now we can proceed with patient testing, you need to indicate, now what happened yesterday? When did this IQC failure issues begin? Did it begin today in the morning? Probably not. The issue may have begun yesterday during midday, or in the evening, or in the night shift. So you need to establish, where did the problem begin? Is it at night, when you had a night staff? What time? And therefore, when they talk about evaluating samples all the way to when we had a successful QC run, it may involve a lot. It may involve just looking at the values you have against the clinical history of the patient, and then probably repeat a few of the samples and see how they are performing, and see whether they are in relation to what the results were yesterday. And so these are key requirements. I may want you to take note of it, because it means now, before you consider running that IQC, there are so many factors you need to consider. Just confirm if your machine is okay. Confirm that this staff who is running IQC is competent to run IQC. Confirm that your IQC materials have not deteriorated, because any failure of IQC now going forward may involve so much, even delaying patient results for even a day, as you try looking at what may have happened and what can be done about it. And therefore, we advise as a position, as a HuQAS view, that before you consider running that IQC, check all the possible causes of failure. And that's what we are calling now risk management. What can lead to this IQC failing? Check at all those points and mitigate them before they actually cause a failure in the IQC. And then quickly now on EQA requirements. I hope we are together. You are so calm. Is IQC causing a concern? So let's now run through the new or the enhanced requirements of ISO 15189 for EQA. Of course, we are now told that a laboratory must now be able to compare their results with other laboratories. And that comparison will include participating in EQA programs. Because that's the only way that you'll assure this patient who is always complaining that your results are not satisfactory, or this clinician who is always not very happy with your results. They want you to refer a test to probably their lab the lab that they appreciate. How do you convince them that your results are similar to what they would get in this other laboratory they're asking you to refer the samples to? So we are being told now, as a mandatory requirement, that we must be able to compare our results with those released by other laboratories. This will give an assurance to you as the person doing the test, because you feel confident that whatever I'm releasing, by the way, if I was to compare it with any other reference laboratory, I would give a similar result. It will also give the confidence to your patients, because your patients are really, nowadays, they're really looking for the best. They're very informed. The patients are very informed nowadays. They're looking for the best. They know about EQA. They know about accreditation. They know about quality assurance in all sectors. And therefore, they may keep asking you, are you participating in these external things I'm hearing? Do you have a third person who can have a look at your IQC your performance and give an indication of whether you are okay or not. Then EQA participation, now than before, will now include the point of care devices. So the point of care devices, we're talking about the glucometers, the HB meters, the blood gas analyzers, the HIV kits as used by our counseling officers, the malaria antigen kits as used by the community health promoters. Now they are called promoters in this dispensation. Now those tests must now be included in IQC as well as EQA. And therefore, for the manufacturers, the suppliers who are around, and even us, we need to encourage them now to ensure that all these gadgets we receive in the facilities as point of care devices should not just have the control strip. There should be a very elaborate quality assurance mechanism for these gadgets, a continuous one. Not just when you are opening a new batch of strips. It should be a continuous quality control mechanism for the gadgets that we are using for point of care devices. It's a huge issue because we always complain these devices should be handled in the lab. But how are we going to bring down the cost of healthcare if we embrace everything? Are we going to be able to go all the way to the field to do this diabetes screening? Probably not. It may cost a lot, and it may not even bring the cost of this universal healthcare coverage that you're talking about down. And therefore, we need to accept this issue of point of care devices. This is an international standard. We're talking about global health. Whatever is indicated on this document is required of any facility, either here in Kenya, wherever in Africa, in whichever continent. Any institution or any country that subscribes to the International Organization for Standardization is required to have these requirements. And it's very critical that we have all those devices in EQA. Now, there is also the establishment of an a procedure for EQA, just like we said for IQC, that the lab must have an SOP for IQC. Now, even for EQA, the laboratories should also have as a list. Among many SOPs, they are going to have an IQC on EQA, or covering enrollment, participation, and even review of these reports. And what do we do whenever there's a failure in them? Now, these EQA samples, just like we said for IQC, should not be handled like, do I say ICU samples? Should not be handled by specific people. They should be handled by any staff who participate in the pre, in the examination, and in the post. And this means, in many facilities we'll find, they will give these samples to anyone to run. But then the person to enter the results, it has to be the quality assurance officer or the laboratory manager. Then it means there's something you have stopped. This person reconstituted the sample. That is pre-analytical. They did the analysis. And then you denied them the chance to also enter the results like they do for patient samples. So it means that IQC program is not fitting the purpose for the post-examination phase. So the lab managers who are around, the quality assurance officers who are around, let us develop a schedule to all our staff. Let them handle that material from the beginning to the end. You may share the samples. If the EQA provider is providing 5 samples, you can ask 3 staff to handle the materials. One to do sample A, B, another one to do maybe C, D, another one to do sample E. But let them handle the material the same way they do with patient samples, handling this material from the pre all the way to the end. So that you're able to know, is this staff prone to critical errors whenever they are entering results? Maybe they have issues with patient testing. You may not be able to know that if you keep assisting them on entering EQA results to the EQA provider. And we also told that this enrollment into EQA, previously it was just a recommendation about ISO 17043. The EQA provider that you are looking for should be accredited to ISO 17043, now as a mandatory requirement. You don't want just to have anybody telling you about your performance. How do you check how is the reliable is their report? Now this reliability has to be confirmed by their accreditation to ISO 17043. Now this standard is the one that guides on how PT materials should be prepared, how the analysis should be done, the statistical analysis involved in IQC, when do you fail a participant, when do you pass them. Now all those guidelines are provided in ISO 17043, and therefore the EQA provider that you want to use as your PT provider must have now, as a mandatory requirement, accreditation to ISO 17043, so that you can check on their credibility as well. You don't want to condemn your analyzer based on a PT report that you may not be very sure about. Then as we continue with the EQA requirements as guided by 15189-2022, as I conclude, these samples, just like we said for IQC, should mimic patient samples as much as possible, or should have the same matrix as what you'd have for patient samples. Again, to ensure that you are challenging your equipment the way it would be challenged by IQC samples. Now, they should have consideration of how are the assigned mean or assigned values arrived at. Is it by independent reference method? Does this PT provider use the overall consensus data? Do they use peer grouping to assign values? Do they use a panel of experts to assign values? These are some of the information you need to seek from this PT provider, even as you consider to enroll yourself into that PT program. So that is those are some of the new requirements in terms of EQA. Now, like we said for IQC, the data should be regularly reviewed. And here, now as speaking as an EQA provider, we usually have a problem when a laboratory participates in a cycle in March. We release reports maybe 2 weeks to 3 weeks after. But then, they will tell you about their failures sometime in July, calling to get some clarification on why they were failing in a test event done in March. Now, that will be the reason why you're doing the EQA. Because this EQA should be reviewed as soon as possible. Immediately you get the alert that the reports are now out, you need to go ahead and review these reports. Make your justification, your judgment about the report that you are receiving. If there are any failures, initiate the corrective actions as soon as possible so that you don't have a challenge. Now convincing anybody that your machine was okay at a particular point, yet you never reviewed on it. Of course, you must ensure that you have a criteria, just like for IQC, on when do you accept an EQA run. Do you rely with the PT provider's criteria, or do you want to set your own, maybe objectives or your goals towards attaining these EQA performance? So then where it is determined that, this is very critical now, just like for IQC, where it is determined that the impact is clinically significant. This is when there is a failure. A review of patient results that could have been affected and the need for amendment shall be considered and users advised as appropriate. Just like we said for IQC, before you do that analysis of EQA, look at all the factors that can cause it to fail. Because if it happens to fail, we'll have a lot to do. You'll have to go back, look at the samples that were analyzed at the same time with this EQA, and see whether the same errors may have also occurred on the patient results. Now, what does that involve? It may involve just probably looking at the clinical history of the patient and the results they are getting. But unfortunately, it may also involve rerunning some of the patient samples that you had released at that particular point. And so, we now see the impact of failure in IQC and failure in EQA. It is not just a matter of triggering the analysis or just reconstituting the material and asking your machine to run. You have to look at so many other factors before you conclude we cannot go ahead and run this IQC. Look at all the factors that can cause it to fail. Because when it does, you'll have a lot to do before you proceed with patient testing. And this is an area I really expect us to maybe do better, because we may find ourselves in very serious situations. Remember, our patients, like we said, are very informed. Some of them, even though they are not health professionals, they have access to these documents. And therefore, they even have an idea what goes around my samples whenever I give them. They have an idea that these samples must be run by equipments that are verified. They must be run by competent personnel. And most importantly, before my results goes out, they must confirm the IQC is okay. Now, what happens when the IQC is not okay? Now, with that background, that our patients are now very, very informed, we need to be very careful on how we handle some of these evidences that they can use against us, either in a court of law. We now have very many lawyers who are not doing a lot in terms of their profession, and therefore, they may want to institute a case against any facility based on anything, on pro bono basis. They will not ask any payment from the patient, but they are willing to represent them for as long as they win a case against a hospital. And they know for some hospitals they get a lot of money. And then they ask the patient to probably get a small percentage, and then they carry the rest. So let's be very careful. We now have a very informed patient base. We have so many people who are interested in the results we release. Social media is working against us in some ways. Any hospital will have some issues, someone attacking them on socials, on how they mishandled a particular patient. Now, it starts from there, and then they now go ahead and ask someone within the facility. You see, there's always this one person who is working with you as a staff, but given a chance, they would attack this facility. So they may be used by some of these people to probably paint you in a very bad image, or to get some money out of these things. So let's be very careful in terms of IQC and EQA. So finally, we as are in total support on the new and enhanced requirements of ISO 15189. Because the changes are meant to improve patient outcomes in the laboratory. The focus of this new standard, they have even put it in the introduction bit, is on patient welfare and satisfaction of laboratory users. And so all these things we are talking about, the intention is to improve the outcome or the laboratory outcomes for all our patients. And therefore we support. Because at one point, Yes, we do service in the laboratory, but at one point, we may also be patients on the other side. Or we may have someone who is a patient at that we know or that we are related to. And so, we really support these changes because whenever you're a patient, whenever you have someone who is a patient, and for the country generally, in terms of reducing the cost of healthcare and ensuring that our clients get the best out of the facilities that we have, we really support these new changes. And every laboratory should ensure the full implementation of these requirements by first documenting an effective SOP on IQC and EQA. All those things that we have talked about, if there's one first step you need to take, is to first of all establish a procedure on IQC, another one on EQA. Start by the authority, the responsibilities of every staff in regards to that process, the criteria for acceptability, what happens when there's a failure, and I have no doubt that we'll have a very elaborate quality assurance program in our facilities in terms of improving patient outcome. And I want to stop at that. I hope I took some time out of you, but I hope we have learned one or two things. So thank you so much.